a joint endeavour between PWSA and FPWR UK. And our aim amongst keeping the community involved is also to support pharmaceutical companies gain approval for the medications that we all want to see for our loved ones in the UK, and that's why we got together to do this. Lizzie, do you want to move on, please? And yeah, here we are. As I said, it's the third in the series, and it's great to be doing these things together, and great for the PWS community in the UK to be coming together like this, to push the message and to engage with you guys, our supporters, and everybody who is affected in some way by Prader-Willi syndrome. Okay, and yeah, this evening will be very much to run through some of the progress we are seeing in UK trials, and also to talk about some of the upcoming trial opportunities. That's really important, because what we do, one is engagement from the community. We depend on that engagement. We know it can be a sacrifice in terms of time, commitment, but it's so important that we do all get involved where we can, and we're aware of what's going on. In terms of the presenters this evening, delighted to have Soleno Therapeutics, who will talk shortly. We've got our very own, from PWSA, Dr. Evelyn Gavers, who will talk a bit more about what people can expect during a screening visit. We've also got Con Science, who are going to talk about a trial up and coming, and Helen Ramage from FPWR UK will fill in laterally with some other information around trials going on from the other pharmaceutical companies. And at the very end, PWSA's Robin Chung will be available with his medical expertise to answer any questions that people might have generally around trials. Okay. So first of all, coming up, we have Maria from Soleno. Maria, I'll give you 10 minutes to talk about the exciting developments and the opportunities around DCCR. I don't think I put too many C's in there. Excellent.
Just the two, David.
Excellent, good.
Yeah, thank you very much. It's Darina actually who's presenting, David, but just Maria is also on the call. My colleague Maria Hall is also on the call.
Excellent.
And I will be able to answer questions just first in the beginning of the call, and then Maria will take any questions at the end. So just to let everybody know. The PWSA UK and FPWR UK for allowing us this opportunity to talk about a burden of illness study which Soleno Therapeutics is sponsoring and which is starting this week. So the timing of the webinar is really fantastic in terms of making the community aware of this study. I should first point out, David, just in relation to your introduction, that this is not a clinical trial.
Yeah, forgive me.
Yeah, that's okay. But just so that everyone on the call is aware, this is not a clinical trial. It's a different type of study, but we believe a really important one for the community and for generating the kind of data on the burden associated with Prader-Willi syndrome, the impact associated with Prader-Willi syndrome on caregivers, families, and the healthcare system. So I'm just going to introduce, next slide, please. For those on the call who don't know Soleno Therapeutics, Soleno Therapeutics is a rare disease company based in California. And we opened our European office initially.
It's the lowest it can go without being muted.
Sorry, could you put yourself on mute there?
It's based in San Francisco, as I say, and was founded to change what it means to live with rare diseases. Next slide, please. And our first focus has always been Prader-Willi syndrome. The company began its efforts in Prader-Willi syndrome back as far as 2017, and we continue to focus on Prader-Willi syndrome today. Next slide, please. So we started in 2017 when the company was formed. And at that stage, our main product, DCCR, or diazoxide choline controlled release, was in our portfolio, and we have spent the last 7 years developing DCCR for the treatment of hyperphagia in Prader-Willi patients aged 4 years of age and older. We launched our phase 3 program, so our clinical trial, which a lot of the rest of this webinar will be about, in 2018. We opened our European office in 2019, and in 2023 we completed our phase 3 program, or our clinical trial program. So at the end of phase 3 of 2023, we had positive results in our phase 3 program, which has allowed us to make a new drug application to the FDA in 2024. And that application is currently under assessment by the FDA. And we've also committed to submitting an application to the European Medicines Agency in the first half of this year. Next slide, please. So this is the team. We are a very small team in Europe. I'm the only member of the leadership team in Europe at this time, but we're doing a lot of work to try and make sure that DCCR reaches the PWS community in Europe. And some of you may know Anish Bhatnagar, our CEO. He has been around since the beginning, and you may have encountered him at various conferences or even webinars in the past. Next slide, please. I think with this audience, I don't need to tell you why or what Prader-Willi syndrome is, but suffice to say that it's something that we have concentrated on and continue to be a huge priority for us going forward. Next slide, please. So in the interest of covering exactly what I'm charged with today, I guess I want to give you a bit of a background to the caregiver burden study, or what we're calling the caregiver burden study. So we all know that PWS significantly affects patient quality of life, as well as caregiver and family quality of life, daily activities, and can often have a negative impact on family relationships, including the need for significant adaptations to normal life, particularly to manage food safety and security. But to date, the real impact of PWS hasn't been well documented or quantified, particularly in peer-reviewed journals, where we can use those data to advocate on behalf of individuals with PWS, where we have concrete data on what it means to be a caregiver to an individual with PWS, what it means to live with PWS. Next slide, please. So we decided that we would run this study to bring the patient and caregiver voice into the formal evidence generation process by generating data directly from caregivers on what it means to have an individual with PWS in your family. We also want to build awareness and understanding of PWS among the stakeholder groups, and those stakeholder groups continue to grow, particularly as we see the possibility of treatments becoming available. So by stakeholders, we mean the community themselves, governments, regulatory authorities, and even other companies. Everyone is a stakeholder in this process. So what we wanted to do was generate data that can be used by ourselves, particularly for engagement with government agencies in relation to access for DCCR. And that presupposes we would get approved in Europe, and that's the first step. And as I mentioned, it's a step that we're concentrating on at the moment. But a lot of these activities have to be done in parallel in order to make sure you have the information at the right time. And ultimately, the study will be published in a peer-reviewed journal and presented at relevant congresses. Next slide, please. So in terms of what the objectives of the study are, it is a multi-stakeholder-led study sponsored by Soleno to quantify the burden of PWS, to engage with the community, and as I say, to build awareness among particularly the key stakeholders, and especially those stakeholders who don't have the same understanding as the PWS community, or those of us working full time in the area of rare diseases and particularly PWS. Next slide, please. So the study design is a questionnaire. It's a questionnaire-based study where an agency working on our behalf will contact a healthcare professional and invite them to participate in the study. The healthcare provider will complete a questionnaire with regard to the patient and their medical history and so on. And at the same time, they will ask the caregiver of that patient to complete a questionnaire in parallel. So we will generate data from both the healthcare professional and from the caregiver in relation to the patient themselves. Next slide, please. So the caregiver question, the healthcare professional questionnaire will aim to generate or collect data on the direct medical costs of care of a patient with PWS. And then the caregiver questionnaire will look at the more indirect costs or the direct non-medical costs associated with caring for somebody with PWS. So by indirect costs, we mean things like impact on work productivity, ability to go to work, educational adaptations. And by direct non-medical costs, we mean things like travel costs to and from appointments, informal care associated with managing or with living with an individual with PWS, companion time, and other home adaptations, including food security, that might be part of your daily life. Next slide, please. So in terms of geographic scope, the study will run in the USA, Germany, France, Italy, and the UK, and will aim to recruit 84 healthcare professionals or clinicians, and each of those clinicians can recruit up to 4 to 6 patients. So ultimately, we're looking to have a total number of clinician forms of 336 and a total number of caregiver forms of 112. So the sample size has been deliberately generated to make sure that the data we generate will be significant enough that we'll be able to publish these data and they will be meaningful in terms of how they reflect the impact of PWS, the impact of caregiving for an individual with PWS. Next slide, please. So in terms of timeline, we started the development of this study in August of 2024, and the next slide, I think it is the next slide, will show the steering committee that we had in place to help advise us on the questionnaires associated with this study. And one of the really significant impacts that steering committee had was the request, and a really, really significant request that we believe will really strengthen the study, to include the questionnaire on the food safe zone as part of the caregiver questionnaire. So between August and December of last year, we finalized the study materials with the steering committee. And in January of this year, we've now got the questionnaires ready for dissemination. So as I mentioned, the study launched, the pilot phase of the study launched yesterday in the UK and the US. And that study will run now until April or May of this year. The exact length of the study will depend on when we recruit the number of clinicians and patients that we would like to include in the study. And then in the later part of the year, we will analyze the results, draft a manuscript, and submit it for publication. Next slide, please. So I mentioned the steering group. We couldn't have done this. We couldn't have prepared this study and launched this study without the help of the steering group. They reviewed the protocol, they reviewed the materials, they provided invaluable feedback in terms of the quality of the materials, and they will continue to be involved as we generate the data and write the final report. The members of the steering group were the Foundation for Prader-Willi Research and in the UK and in the US, and the Prader-Willi Syndrome Association, also in the UK and the US. And Dr. Evelyn Gievers, who I know is on the call and who was an incredible support in the development of this study, and Dr. Catherine O'Brinba, who is a PWS expert from the US. Next slide, please. So lastly, how can you help, or what can you do in terms of your involvement in this study? Well, to be clear, your clinician would be the first point of entry into the study. So the agency running the study will contact the clinician, and once they've agreed to participate, they will identify patients and caregivers who they feel are suitable or who meet the criteria for the study. In terms of how you can help as a caregiver for an individual with PWS, you can mention the study to your clinician and encourage them to participate if they've been invited. And if you would be willing and keen to participate, you can certainly make your clinician aware that that's something you would be willing to do. And then part of your involvement would be to complete the questionnaire and return the questionnaire. The questionnaire will be available in electronic format. You will have the opportunity to do it at home in your own time. So it's not something that you will have to do with any degree of pressure. You will be able to stop and start the completion of the questionnaire just in terms of your own time. It should take no more than about 30 minutes to complete online, and there will be a small honorarium for participation. So if that's something that you would like to be involved in, we would be delighted to have your support, and we would thank you very much for that support. And we're happy to answer any questions in terms of the study and the study design. I can certainly try to answer those questions now. I appreciate, David, that you have a question and answers at the end. But as I say, my colleague Maria Hall is also here, who was also instrumental in the development of the study design, and she'll be happy to answer questions at the end as well.
Okay. Thanks so much there, Doreen. That was really interesting. Forgive the earlier introduction. I'm so long associate DCCR with yourself, so I went on autopilot there.
I know, but I just don't want to disappoint. So yeah, just to make it clear, there isn't another study at this stage.
Absolutely, yeah. And great to get that update. It sounds fascinating. Okay, so we're just going to move on. We do have the questions answer opportunity at the end. So if there's anything regarding that previous slide deck, please, feel free to ask as we go on. But in the meantime, I'm going to pass over to Dr. Evelyn Gievers, who's going to give us a presentation on screening visits and what you can expect. So I'll pass over to you, Evelyn. You've got about 15 minutes, if that's okay.
Yeah, that should be fine. So thank you very much, David, for the introduction. Yeah, also, of course, thanks to PWSA. And we discussed previously what would be useful to discuss on a webinar like this. And we felt in the hospital that often parents and family do not quite know what to expect at a screening visit or a baseline visit, and that a lot more happens than they initially may think about. So therefore, I'm going to tell a little bit about what happens at a screening visit, and I'll do that together with our clinical research facility nurse, Grace Wald. So for people that don't know me, I'm a pediatric endocrinologist. I work at the Royal London Hospital in East London, which is part of Barts Health. And we are affiliated to the university, Queen Mary University, and we also have in the hospital a clinical research facility where we do clinical trials for specifically for children. We have a separate clinical research facility for adults. So the outline of my talk is what happens before the screening visit, what happens at the screening visit, what happens after the screening visit, and then a little bit about what happens at the baseline visit. So how does the whole process start? So usually that starts with either families contacting the research facility that are interested in a study, or us asking our patients in clinic whether they are interested in the study. There are always very strict rules around clinical trials. So we are only allowed to ask people whether they're interested in the study when the study has officially opened, when everything has gone through an ethical committee. And we're only allowed to send out leaflets that have been seen by an ethical committee and approved. And again, only at the time that the study is actually opened. So then when
Sorry, Evelyn.
Yeah.
I'm just looking for the slides haven't moved on here yet.
Yeah, sorry. I was
Okay.
moving my own slide, sorry. Yes. So before the screening visit, family contacts us and we then send out the patient information leaflet. Then we contact the family, usually about 2 weeks later, so they have had a chance to look at the information, and then we discuss whether they are interested to participate. The leaflet usually gives information about what the drug is, what it does, what the side effects are, what the question of the study is, how long the study runs for, whether there's a dummy drug involved, and then also usually a table of all the different procedures that will need to happen during the study and at what clinic visits to the research facility. So when we then contact the family, we discuss any questions, and we also ask whether they allow us to contact their consultant and their hospital to ask for their letters for the medical history. Because we will need to find out whether the child fulfills the criteria to be included in the study, and also ensure that there are no exclusion criteria that prevents the child to be included. So we then write to the pediatric endocrinologist, ask for the clinic letters, and also ask for a copy of the genetic testing of Prader-Willi syndrome. And it is surprising how difficult that sometimes is, because often that maybe many years ago, may have been in a different hospital, different country. So there are lots of difficulties that we already come across at that stage. And then from the letters, we try to roughly assess whether we think the child is able to be included in the study. Sometimes that requires us to get back in touch with the consultants to get more information. So here on the right, you can see for this presentation, I've taken the Acadia study as an example with carbetocin, because that's a study that's running at the moment. So here you can see the key inclusion criteria that are on the leaflets that Acadia sends out to the Prader-Willi syndrome associations, and that has the major inclusion criteria on there. But there are also other inclusion criteria that are quite important. For example, has your dose of growth hormone increased recently? Have any other drugs been started or stopped? So that's all information that we need to look at. Next slide, please. This already shows some of the major exclusion criteria. I've highlighted a few. So it has clinical significant cardiovascular disorder, renal, liver, bowel, or lung disorder, including severe asthma. And we then need to assess whether we think a particular condition is clinically significant or not. And also other conditions. But then, next slide, please. There's a whole more list of full exclusion criteria. So for most studies, this is quite similar, and most of the time there are at least 30 to 35 exclusion criteria why you're not going to be able to be part in the study. Still, most of the patients that we screen will be eligible to go through to the baseline visit. But that is why it is important to already pre-screen patients, so you don't disappoint after having seen family in the clinical research facility. So I've just highlighted a few. So it has had major surgery within 1 month of starting the trial. That's an exclusion criteria. Is not willing to omit any drugs that are given through the nose, because carbetocin is a medication that you take through the nose. So that also includes potential flu vaccinations that you can take through the nose, asthma medication. So it's an important exclusion criteria, and also new food-related interventions that have started in the last month. So before we can include a child in the trial, we need to be able to tick all those boxes that these exclusion criteria are not met. Next slide, please. So these are the study procedures. So here in the first column of this table on the left and the right, you can see all the procedures that are required at a screening visit. And in the second column, you can see all the requirements for the baseline visit. So there are part of it is history, part of it is examination, part of it are additional tests, and part of it are the questionnaires. So we need to go through all those things at the baseline visit. Next slide. So what happens from a medical point of view then at the screening visit? So the child and their parent, at least one of the parents or two parents, arrive at the clinical research facility, and the first thing we need to do is make sure that they are willing to take part in the trial and that they sign the forms. Before the forms are signed, we aren't allowed to do anything. We're not allowed to take any blood or do anything else. So that means that we need to discuss with the child and the parent the main features of the study, go through the patient information leaflet, and go through the consent form and make sure that they have no more questions and they know what they signed for. So consent is what's given either by a patient or by the parent or another legal guardian if the patient isn't able to consent by themselves, so give permission by themselves. So usually children are not able to give permission by themselves, and a parent does it for them. Assent means that you do involve the opinion of the child, but the opinion of the child is not the major opinion that will definitely stop them from being included. And it also doesn't necessarily have to be taken. But we would be very reluctant to include a child in a study if the child is very clear that they don't want to be included in the study. So there's a special form for at an age-appropriate level where we ask the child whether they want to go ahead with the study. So when those forms then are signed, then also the caregiver, who is not always the legal guardian, needs to consent that they will be happy to be in the trial and that they will do what's required for the trial. So most of the time, the caregiver, if the caregiver is not a parent, then maybe somebody from a home that looks after the adult, or from a boarding school where the child spends most of the time. Then we need to take a detailed medical history to ensure that the child is allowed to be included, but also to understand all the different events and conditions that the child has. Also really important, any ongoing investigations, any current medical problems, and what the current medication is. That can sometimes take a long time because we need to have all the details. How frequent? What is the dose? When was it last changed? Then we also discuss the hyperphagia and the management to get a good feel for how that is at the moment, because further in the study we will need to compare to the initial assessments. But this assessment at a screening visit is really the assessment whether the child is able to progress to the baseline visit. Discuss all the problems of Prader-Willi syndrome that the child has, any other conditions and treatments, and general well-being of the child. Then a medical examination of heart, lungs, bowel, skin, neurological examination, and again to ensure that there are no exclusion criteria and reasons why the child cannot be included. Next slide, please. So here I hand over to Grace.
Hi there, my name is Grace Wild. I'm a research nurse in the Children's Clinical Research Facility, also at the Royal London Hospital. So I'm going to talk about some of the kind of nursing assessments that we also do at screening visits. So weight, height, blood pressure, heart rate, respiratory rate and temperature, ECGs normally, and then blood tests, for example, hematology, biochemistry, thyroid function. With the blood tests, if there are abnormalities, then sometimes there's the possibility to repeat a specific blood test within the screening window. And then also urine test and pregnancy test if applicable. Okay, next slide. So questionnaires, as Dr. Givers has already mentioned, the questionnaires are filled in by a caregiver, usually parent or guardian, but could be, say, a key worker from a residential setting. So the important thing is normally that they spend enough time with the child, and that can be different depending on different studies, but will have usually quite specific criteria. The caregiver is given a login so they can complete questionnaires on their own device or a device provided, which is usually when the hospital Wi-Fi kind of fails, and it can take a bit of time, but we get there. So a few examples of the questionnaires that we would have: hyperphagia questionnaire for clinical trials, PWS anxiousness and distress behaviours questionnaire, and food safe zones. Okay, next slide, please.
Evelyn, you're on mute.
Sorry. So yeah, after the screening visit, we then assess the questionnaires and we assess the blood results that are usually back after 2 days, the ECG, any other investigations. And we need to look at all the results that are outside the normal range. Are they clinically significant? Are they in exclusion criteria? Do we need to do other tests or repeat to ensure whether they are able to be included in the trial? Then we go back to all the inclusion and exclusion criteria and make sure that indeed all inclusion criteria are met and there are no exclusion criteria that are met. Sometimes that requires us to discuss with the medical monitor of the trial who oversees the trial and discuss whether we feel that what our opinion is about whether a child can be included or not and whether they agree. Sometimes, very often, there are gray zones and we discuss. And then at the end of the process, there hopefully is then a decision to progress to the baseline visit. The baseline visit is usually about 2 or 3 weeks later. There's a very set window, how long, what the latest is that you can see somebody back for the baseline, or otherwise you need to repeat the whole process of the screening.
I think there's another slide there.
Sorry?
Yeah, that's a slide. Excellent.
Yeah, exactly. And then at the baseline visit, so that is a really important visit where everything will be compared with. Lots of things will need to be repeated from the screening visit because this is the time that you compare things with. So we want to know any events that happened since screening, an updated medical history, updated investigations, change in medication, need to examine again. We usually need to do blood test again, ECG again, questionnaires again. And then on that day, most of the time, fortunately, it's decided that we can progress, and then we let the pharmacy know that we are happy for the child to progress. The company is happy for the child to progress, and then the pharmacy will randomize. So by luck, so the computer does not actually take a token whether a patient will get the placebo or the actual drug. Then the pharmacy prepares it or takes the pre-prepared medication, and then the medication needs to be collected, and everything is double-blind, so the person who collects the medication is not aware whether it's placebo or drug, and all the procedures will be very carefully orchestrated so that nobody knows whether it is actually drug or placebo. And then at that visit, the first dose of medication is given, so it is clear that everybody, that the caregiver and the knows how to administer the medication, and that the child's actually able to take the medication. Next slide. So here I hand over to Grace again.
Yeah, so a few kind of extra of the nursing bits at the baseline visit. So there can be additional questionnaires, and the questionnaires can kind of change a little bit throughout as a study progresses. So teaching, we practice setting up medication and discuss how to give it, when to give it, how to store it, and how to transport it. We'll also go through any diaries or any kind of documentation that needs to be filled in by the caregiver. So once we give the first dose of medication, so we are required to do an ECG after, and then after that, blood tests for pharmacokinetics, just to check what the body does to the drug once it's inside. As soon as the ECG as possible. We'll also be kind of obviously monitoring the child for any signs of allergy or anaphylaxis. And then medication is taken home in the transporting cool bag provided. Next slide, please.
Oh, Evelyn, you're on mute there.
Yeah. So we hope that this has clarified the process a little, and of course we're open for any questions, but probably at the end, I think.
Just before, I'm conscious of time here, but we've got Mariana's came in here with a question, and we'll just try and deal with this quickly in the chat. And she's asking, is it worth mentioning that the screening questionnaires cover the past 2 weeks as timeline, which are then completed again during the baseline visit? And if the score comparison deviates from the first screening, then the individual is likely to be rejected to proceed with the trial.
Yeah,
It's
so
more
there
of a statement rather, because this is what we experienced. Sorry to interrupt. It is what we experienced, rather questioning that that's the case. So that's from what happened with my daughter and myself a couple of months ago, for good or bad reason. But I think it was a learning curve for us, my daughter as a patient and myself as a carer, but also the medical team. So that's why I think it's important information to be shared.
Yeah.
Oh, okay, thanks for that.
Yeah, so indeed the questionnaire is always, well, it depends on the questionnaire, but the HQCT asks for the last 2 weeks. I think, of course, there can be differences, and I think it won't be a straight, you can't be part of the trial if the questions the second time are different, or if the answers the second time are different to the first time. But most of the time there will be a question raised if there's a major change, because that's unusual. And if there isn't a clear reason for it, then maybe that may lead to exclusion. We have not experienced, in the Acadia trial, we have not experienced that. We don't, yeah.
I'm sorry again to interrupt. Probably that is a bit of a lack. Just to clarify quickly here, I think because we've been preparing so much for that trial, the screening outcome came up as a better than what it is usually. So I think we kind of overdid in terms of preparation, trying to navigate change, and this had a negative effect on the outcome of the baseline questionnaires. So
Yeah,
yeah,
I
there should be in the
understand.
middle.
That can be really, really disappointing. I think the most important is to always answer the questionnaires honestly, and mimic and reflect what has happened in the last 2 weeks.
Okay.
Which was the case.
Yeah.
Yeah, thank
Yeah.
you.
Okay. Okay, guys. Yeah, no, that's interesting, but I'm just conscious of time. So we're just going to move on to Sarah's joined us this evening from Conscience, and she's going to talk through CSTI 500. So I'll pass you on, Sarah. If you can, I'll give you 10 minutes here. That'd be great. Thanks.
Thanks, David. Yes, so good evening, everyone. I'm Sarah Sheldrick. I am Research Director at Conscience. I'm based here in the UK, and I've worked for Conscience for 5 years now. So firstly, just thank you to the organisers for the invite to speak today. It's great to be able to share with you all what Conscience are doing and to tell you about CSTI 500. So this is our triple monoamine reuptake inhibitor for Prader-Willi syndrome, and I'll try to describe a bit more about what that actually means over the next few slides. Next slide, please. So as we all know, PWS is a genetic disorder, and it's due to the inactivity of specific genes, which then leads to those hallmark symptoms of hyperphagia, anxiousness, irritability, as well as frequent temper outbursts. And whilst we're hopeful that DCCR will be approved soon, as it stands today, there's currently no approved therapies. So, and when we look at the therapies in late clinical development, they are primarily targeting hyperphagia, but often aren't always addressing those other neurobehavioral symptoms such as anxiousness, irritability, and temper outbursts. So there's a real unmet need for therapies that can do both, so target hyperphagia as well as those other symptoms. And that's what we're hopeful that CSTI 500 might be able to do. Next slide, please. So, as I said, CSTI 500 is a triple monoamine reuptake inhibitor. So a monoamine is a chemical signal or a neurotransmitter that works within the CNS to regulate various different functions. So 3 of the key monoamines are dopamine, serotonin, and norepinephrine. And they all have various different roles and involved in different functions. And some of those functions are displayed on this Venn diagram here. So you can see we have functions such as mood, irritability, impulse control, appetite. And as you can tell, all of these are also important in PWS. So that's not surprising, as there's research out there to show that individuals with PWS have low levels of these monoamines. And we think that this deficit might contribute to some of the symptoms that we see in these individuals. So the goal with CSTI 500 is to help normalize the levels of all 3 of these monoamines simultaneously. And we're hoping that therefore we might be able to achieve a more comprehensive symptom management approach with this therapy. So we might be able to achieve benefits across more than one symptom with just this one therapy. Next slide, please. So we also have a tunable feature. So the illustration on this slide here is based on some of our early clinical work. And what you can see is that at lower doses, so the lower blood drug concentration, CSTI 500 primarily blocks serotonin transporter, which is labeled as SERT here. So when we block that transporter, we increase the levels of serotonin. And we think that this will help to stabilize symptoms such as mood and reduce irritability. And then as we gradually increase the dose, it further blocks the dopamine and the norepinephrine transporters. And we hope that as you increase the dose, you can then start to address hyperphagia. So this tunability is really important in PWS because we know it's a complex disorder and each patient can present differently with different symptom severity. So CSTI 500 will enable us to get the dose and the balance of these monoamines right for each individual to hopefully maximize the benefits as well as, of course, minimize any side effects. Next slide, please. So to ensure that each patient gets that correct dose, we're also going to use PK guided dosing. So PK stands for pharmacokinetics, and it's essentially how the body processes the drug, how it's absorbed, how it's metabolized, and that PK can differ from individual to individual. So with this dosing approach, patients can collect a small blood sample at home with a self-sampling device. That blood sample is then shipped via a courier, such as FedEx, to a central lab where the blood sample's analysed for their blood drug concentration. That data is then fed back into our PK model, and based upon those results, the data is then analysed, the dose is revised if needed, to ensure that patient is getting the right dose for them. So this process moves us away from guesswork and traditional kind of trial and error dosing, and potentially allows us to have more precise control over symptoms as well as control over safety. Next slide, please. So just wanted to finish with the clinical status of this drug. So we've already completed our phase 1 clinical trials. So we've done that in both healthy volunteers as well as in a small group of individuals with PWS. Those phase 1 trials showed that CSTI 500 was well tolerated. It had a good safety profile. And importantly, we saw that it reached the brain targets that we were aiming for. So all of this data then supports us moving into phase 2, which is where we're currently at. We are still in the planning stages for our phase 2 study, so the sites and the timings of that are still to be confirmed. But we know that that study will further evaluate the drug safety, the tolerability, and also start to look at the benefits it might be having on various different PWS symptoms. So the endpoints we'll look at will be hyperphagia, as well as other behaviours such as irritability and anxiousness. And we will be implementing that PK-guided dosing approach to individualise the doses. Next slide, please. So thank you for your time today, and I'm happy to try and answer any questions, but also please do feel free to reach out via email if you've got questions after the webinar as well.
Okay, thanks so much, Sarah. That was really interesting. I'm now going to go on to Helen, our own Helen from FPWR UK, who's going to give us a summary of other activity going on at the moment.
Thank you, David. So hi, everyone. Yes, we've got 3 trials that we'd just like to bring you up to speed on as well. So if anybody was able to attend the second webinar that we held, Arcadia came onto that webinar and gave us a great insight into their COMPASS trial. So a bit of an update today from them is that the recruitment for the trial is going well. There is still the opportunity to take part in this trial if anyone on the call or watching this on demand is interested. Please have a look at the website. They are recruiting at 3 sites, so Glasgow, Birmingham and London, which Dr. Gevers mentioned earlier. So, again, the inclusion criteria are up on the screen. So you need to be between 5 and 30 years old, the PWS person. You need to show hyperphagia. And also importantly, you need to have the carer be able to go with the person to the study visits. So I know that we've been through that earlier on this call as well, but just to let you know, that opportunity is still there. So if anyone is interested, you can look at the website, and the phone numbers are on there for the sites. And if you just give the sites a call, they're extremely helpful, and we'll talk through the trial. Thank you. So Liz, next slide. So Harmony Biosciences, again, they came on the previous webinar as well, and their trial is around excessive daytime sleepiness. And their trial is the TEMPO trial. Again, this is very different because all the other trials we've been talking about have been really around hyperphagia. This one is very much focusing on daytime sleepiness. So they hope to get the go-ahead for the trial to be in the UK in March, which means they're going to aim by the end of May to have 4 sites open in the UK. So this is really exciting. We'll keep you updated. So, if you do sign up for our mailing lists, I think there's a slide at the end with the details on. We can keep you up to date with all of these trials. So at the end of May, there should be one open in Hull. There'll be the Ninewells Hospital. I looked these up. So Ninewells in Dundee, Fulbourn Hospital in Cambridge, and then Royal Hospital for Children and Young People in Edinburgh. So that's a very exciting trial that's coming up, and they hope to have all the participants enrolled by the end of the year. That's excellent. Finally, Aardvark. Again, we had a great update on this one previously from Tien. So it's their trial is around hyperphagia, and their drug is called ARD-101. So if we can just move on, Lizzie. So Aardvark's drug is for treating hyperphagia and PWS. It's an oral tablet that you take twice a day. And they have completed their phase 1 and phase 2 trials. So remember, in a clinical trial, there were 3 phases. 1 and 2 are complete for Aardvark's trial, which is great. They had positive findings in their phase 2 trials. So they found that their drug helped to reduce hyperphagia. It helped to reduce anxiety and also food-seeking behaviors. So positive results, which means they're now planning their phase 3 trial, which is the trial before they go for regulatory approval. So this is a really important trial, the phase 3 trial. And Aardvark are looking to open up sites in London, Leicester and Glasgow. So good coverage in the UK. And they're looking to do this in Q3 of this year. So again, we will keep you informed about all of these. Very exciting. Now, the criteria for this trial is you need to be 13 years and older, and you'll be taking 2 tablets a day over a period of 12 weeks. So the trial will last 12 weeks, and then afterwards there'll be 4 weeks of observation. And importantly, at the bottom here, it talks of an open label extension. So they're looking for an open label extension, and this means that if you take part in the trial for the 12 weeks, you may then be able to continue on that drug for a certain amount of time afterwards as well. So that's a really something to keep an eye on as well. What you would need to do to take part in this trial is 4 visits to a clinical site. So one of those that we mentioned there, London, Leicester or Glasgow, but also 3 telehealth visits. And that's just like this kind of Zoom call where you'll have a consultation over a video call with the clinician. So that's Aardvark's one in a nutshell. If we can go to the next slide, I think we can skip over the next slide. If we just go to the next one, Lizzie. So Aardvark gave us a little bit of detail on their phase 2 trial. This is what happened on their phase 2 trial. There were 18 people with PWS taking part, and there were no serious adverse effects. So that's, really positive on the safety side as well. If we skip to the next slide. And again, this is a bit more detail about the phase 3 trial we just spoke about. On the left-hand side, you've got who can take part. So the eligibility criteria, so it's 13 years older, medically stable, and so on, the last 2 bullet points there. And on the right-hand side, they're looking to, the primary endpoint is actually what they're looking to measure. So they're looking to measure hyperphagia. Does it reduce hyperphagia? They're going to use the HQ-CT questionnaire as well, which has been used in other trials. And caregivers and physicians will be filling out questionnaires as well for them. So quite an exciting trial coming up for Aardvark as well. So we'll keep you informed on that one. So that's the 3 other trials that we wanted to bring you up to date on. Now to the Q&A, David.
Fantastic. Thanks very much, Helen. Okay, so we've got a little bit of time for questions. I had one which came in, and I'm just going to read this one out. So it was a question about how does one hear about UK-based trials? This is from a person who has signed up to the FPWR register, but it's a US one, so they only get notified or hear about trials in the USA. And of course, we do now have activity in the UK, as we all know. So that's a question. Does anybody want to pick that one up? About notification of trials in the UK? What's the best way?
I think we would just say keep an eye on the PWS Stronger Together website, where we would have all our trials listed on there, but also on the screen there you've got the mailing lists as well, so you can sign up to receive updates from the organisations, the FPWR and the PWSA. Yeah,
and I shared that link in the chat there, Helen, around a Compass trial as well.
Yeah, I would say the same, because there's no one single database or website in the UK where you can look at all the trials. You can look at the US website which will say which sites are involved, and they will also list the sites outside the States. But the easiest thing is to look on the websites of PWSA and FPWR. Whoever will get asked to be involved in a clinical trial in terms of clinicians and hospitals will get in touch with PWSA.
Okay, thanks very much. Another question which came in, this is from Evan Close. Is there an age range being considered for the CTSI 500 phase 2?
Yes, so at the moment it looks like the age range will be 13 to 50 years old.
Okay, thank you very much. And then the final question that we've got in the chat here is from Mariana, which is to do with the ARD trial. So we might not be able to answer that, Helen.
If I can help, I'll be glad.
Yeah, please. So the question is, could ARD trial be combined with, and forgive my pronunciation here, Mounjaro treatment, or if approved for the trial, could the patient pause Mounjaro or have to stop it completely?
So there's a given time before starting the trial where it cannot be changes, and we will provide the details in the protocol.
Okay. Okay, good. Thanks for that. Is there any more questions that anybody has? You can come in and ask it, or you can use the chat function if you wish. We've got a couple of minutes left.
I can just add to that last question that for most trials, it will at the moment still say indeed that medication like Mounjaro and liraglutide and Wegovy is not allowed. And in general, for most trials, it will say that major changes or start of medication within a month or 2 months or 3 months beforehand is not allowed.
Okay. Thanks for that, Evelyn. Okay.
Thank you as well.
Excellent. Okay, guys. Well, I'm not seeing any more questions, but I think tonight was extremely informative. So I'd just like to thank all the presenters for giving us their time. Thank you to everybody who's turned up this evening. It's great to see this so well attended. As I said at the start, we do, I think, live in interesting and exciting times, and it is about making sure we're informed as a community so that we can participate as fully as possible to support the great work being done at the moment. This is of course recorded, so you can access at a later date. If you know of anybody that was unable to make it this evening or would have liked to, please feel free to share on social media so that people know about us, know that we do put events on, and that they can access this evening's recording as well. But otherwise, guys, that's it from me. Have a wonderful night, and thanks for your time.